Good afternoon, everyone, and welcome to our PSO members. Thank you for joining today, our Model Opioid Practices for Healthcare Workers. We would like these meetings to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started, I'd like to go over the logistics for today's session. As previously noted, the lines are currently muted and in listen-only mode. During Q&A, you may ask a question or make a comment by raising your hand by clicking on the hand icon on the Grab tab located on the left side of your control panel, and your line will be unmuted. Please announce your name and organization prior to speaking. Feel free also to ask questions or make comments using the question box located in your control panel throughout the session. This session is being recorded and will be made available on the NCHA website through email notification shortly after the conclusion of this session. Presenting for you today is Evan Frazier, PharmD BCPS, Director in Controlled Substances Diversion Prevention with Duke University Health System, and Angela Livingood, PharmD BPGP, a Pharmacy Manager with Pender Memorial Hospital. At this time, I will turn things over to Jay Kumar with the North Carolina Healthcare Association.
Thank you, Sarah. Thank you guys so much for joining us today. We are really excited to be able to share these tools for you. The neat thing, Evan and Angela have worked really hard along with others to help develop the Healthcare Worker Diversion Toolkit. You can find that at ncha.org/diversion. But the real goal of this webinar today is to think through how you and your institution can implement this toolkit and what ways you can ensure that not only are you being safe for your patients, but you're also being safe for your employees to ensure that we have lower harm events and can take care of them. So throughout the webinar, you'll have some real world examples of things that went well and things that sometimes went wrong for systems, along with opportunities to think through how you may engage in implementing this program. Also, I wanted to give a short plug for the Coalition for Model Opioid Practices. That is an organization that is led here at the association, and as member hospitals, you are all welcome to participate. Diversion, health system response, and then prevention and safe pain management. There are many members of your institutions that are engaged in that work, from video development for patient safety to this toolkit to ED response pathways. And Madison Ward Willis is our project manager and performance improvement specialist that oversees all of that work. And she's with us as well if you have questions about that. So without further ado, I'm going to turn it over to Evan and Angela so that they can start going through this toolkit. Again, if you have any questions or comments, feel free to jot them in the comment box or raise your hand when the time for questions arises. Thank you. So this time, Evan Frazier will get us started.
Yeah, good afternoon. Thank you for joining us to this webinar. I apologize, I'm trying, it's not working for me right now. So this is our overview of the work that's being done by the Hospital Association with our model for opioid practices. And as Jay mentioned, there's a lot of work that's going on in all of these areas. And within each of these areas, you can see the things that we're working on. So for today, we will be focusing in on the bottom part, the healthcare worker diversion, talking about the prevention, workforce wellness, structure, monitoring, surveillance, reporting. I apologize for the, so I can see there highlights what we're going to be working on. those sites and a lot of other requirements that have been made. One thing to note as we go through and we talk about this, we will point out some of the information that was provided by the DEA to these sites and the things that they needed to ensure were in place. But of note, each of the major instances where the DEA went into a site was the result of a harm incident that occurred. And whether that was an incident that led to patient harm or an employee being harmed or something, there was a event that led to the DEA coming to the site. And so I think that's important. There's always a lot of focus on, what would an institution do if the DEA came and was fined, $4.3 million. But it's also what happened prior to that in order to cause the DEA to come. And those were the events that did lead to patient impact, patient harm, as well as impact on the staff members of those institutions. So as we go through, we will highlight some of the information from each of these so that you can have that as well. So just a little bit of an overview with the toolkit. As already been mentioned, we are dividing it up into several different areas. Angela will talk to us about employee wellness and staff education, and then I'll go into a little bit around the structure of our diversion program, how to monitor that, and the reporting requirements of a program. But as we go through, we'll also try to emphasize that the backbone of all this is to ensure that our patients are receiving the proper care, that our staff members are in the right mindset and in the right frame of mind to provide the highest level of care to ensure that patient safety does occur. And so I wanted to give a few acknowledgements. As Jay mentioned, this was a lot of work from the coalition in putting this together. It wasn't something that Angela and I did on our own. You can see here we had a lot of participation from many organizations throughout the state, which we are very thankful for, because they did provide us a lot of great input into what we needed to focus on and how we needed to structure this toolkit. So with that, I will turn it over to Angela, who will get us started with talking about the employee wellness and education.
Thank you, Evan. Hi, everybody. This is Angela, and we're going to start with prevention and workforce wellness. And the first piece that we're going to go over is some tools to help you develop a wellness program for your employees. So we as a team, when we got together and talked about and reviewed the research of what the goals of workforce wellness should be, we came up with three predominant ones: to increase resilience, to promote clinician wellness, and reduce burnout. There we go. And the benefits of an employee wellness program include impacts on all 5 of these dimensions. And that's a wonderful thing to provide to your employees. There's evidence that shows work site health programs reduce absenteeism, reduce healthcare costs, and reduce workers' comp and disability claims. Poor employee health has been shown to adversely impact productivity. And so there are websites within the toolkit to give you more information on what the employees, the employer, get from having a wellness program through the workplace. Okay. Our toolkit divides wellness program development into 4 parts: assessing, planning, implementation, and evaluation. And again, there are great resources within the toolkit that can be used in larger hospitals or smaller hospitals. Just to note, as Jay mentioned in our intros, Evan works at Duke and I work at Pender Memorial, and the size difference between our facilities is significant. I work at a critical access hospital, and Evan works at one of the leading academic medical centers in our country, but we can all get something out of this development plan. So a comprehensive program should pay special attention to mental health. In particular, healthcare workers are susceptible to what is known as compassion fatigue, which is composed of both burnout and secondary traumatic stress. SAMHSA has wonderful resources for use to educate your leaders, yourself, and your teammates about compassion fatigue and burnout syndrome. And we would encourage you to investigate that to see what you can bring back to your facilities. And we also encourage and give information about employee volunteer programs. 9 out of 10 employees who volunteer outside of work get an emotional burst, an emotional release that just re-energizes them and reinvigorates them for time in the workplace. 78% report lower stress, and 94% claim an improvement in mood. And perhaps even more significantly, 89% of employers report that there's a correlation between their employees volunteering and their employee engagement, which is wonderful. So to prevent diversion, healthcare workers in particular are prone to work-related stress, as we've mentioned just previously, given just the environment that we practice in. When there's a shortage of time, or if the employee or a team member lacks positive coping skills, such as having an outlet for exercise or relaxation, one of the coping mechanisms that's often reached for is to use alcohol or a substance like an illicit substance or even prescription medications. Because there is such easy access to controlled substances within the healthcare facility, drug abuse among healthcare workers can lead to drug diversion in the workplace. The toolkit provides resources that are listed here to help you evaluate your current workplace wellness program, or if you want to look at even starting one. There is a wonderful section in there in the toolkit that you can use to benchmark what you have or to figure out where to start your own. So please, please, please consider looking at this when you return to work. Next, we're going to continue down our path to looking at diversion awareness education. So here is one of our references to the previous settlement Evan talked about. In the settlement agreement between the DEA and this healthcare facility, they had to commit to providing employee orientation materials designed for education at new employee orientation, and then also have annual mandatory online employee training, again, designed to prevent drug diversion and create awareness about diversion within the workplace. So what should your education program include? As listed on the slide, there's some minimum contact to have, but I think the greatest thing that can come from general education is to make everyone aware that diversion can happen through or by anyone. Some of the most Common comments when someone is suspected of diverting or has been found to be diverting are that I cannot believe that he did that, or she is such a great teammate. I cannot believe that she would divert from our nursing unit or our pharmacy. So just that is a huge piece of education. So define what drug diversion is and what the consequences are. How to recognize if a teammate may be impaired or have any concerning signs that they may be abusing a substance. Make sure that your team knows how to report any suspected drug diversion activity. And there should be an option to do so anonymously. Now, in the ideal setting, we would love to have the name of the person that is suspected as well as the name of the person reporting so that we can follow up more fully and more quickly. But we also don't want the need to give your name to be a reason why people do not report. It's important for everyone in the hospital to have some level of diversion education. And this general education is needed because controlled substances can be found in bed linens, in the floor, in the hallways and stairwells, or in the bathroom. And if your team member finds that, he or she needs to know what to do and who to go tell. In addition to these general requirements, there may be people at your facility who need more in-depth training or specialized training. And this would include people and staff who handle controlled substances. So this goes beyond nursing and pharmacy to EMS or any other physicians who have controlled substances in their office, supervisors, prescribers, security. So all of these folks, you may consider doing a more in-depth and specialized education program. Within the toolkit, we have provided for you examples of education that has been used throughout other organizations. We also have provided links to articles and examples from other organizations, and we encourage you to use it, to download it, and adapt it to your needs. It's not copywritten. The slides that are in there, so please feel free to use. And we also ask that you share if you feel like you have some good information or good controlled substance education material already. Consider sending it to us so that we can add it to our toolkit. Now I'm going to turn it back to Evan so he can delve into the last three parts of our portion of the overall model.
Thank you, Angela. And just before I get into these last three parts, I just wanted to emphasize what Angela had pointed out. With our employee wellness and the programs that you put into place, there's as you mentioned, there's various ways that you can do that, but that does, if we take care of our employees, it helps them to take care of the patients and to provide that enhanced patient care and improved patient care. And when we look at that compassion fatigue that Angela mentioned, that can, when our staff members are looking at patients rather than as a patient, more as an object, that can happen during that passion fatigue, then that can negatively impact the care that's being provided. And then use that education that Angela talked about to help the staff make that connection between what we're doing around diversion and the need to prevent diversion of controlled substances and how that does link back to patient safety. Staff members tend to respond better to things if they know why we're doing it, and it's not just another step for them to do, not just something else that they have to do because of regulatory compliance or things that don't mean as much to them. But when this is going to help us provide better care for our patients, that is something that does resonate with them a little bit better. And so as we go along and talk more about this, I'm going to combine these next two together in one with the program structure and monitoring and surveillance of how you can put together a program if you don't have one already, or if you do have one, things to think about to ensure that your program is robust enough to be able to do everything that needs to happen. And so when we think about a program structure, keep in mind that diversion can happen at any point during the medication use process. So that can be at procurement, preparing, prescribing, administration, wasting. And there's examples that I can give you in each of these areas of when that diversion has occurred. There's been recent news of pharmacists who was diverting medication on the procurement side, that they were ordering more than what was being entered into the system, so that they were able to divert that. And they're preparing and dispensing, that can happen on nursing or pharmacy side. The prescribing, ensuring that our physicians are aware of proper prescribing habits, which is one of the arms of our coalition to help them with that education. And then the administration, wasting, and returning, a lot of diversion can happen in each of those areas as well. And the things that the DEA looks for, one, are there security controls in place in each of these areas? In the most recent settlement, they call that specifically on waste, because that is a high-risk area for diversion. But one that we may not think about as much is the returning of medications, where a user pulls out fentanyl for a patient and then removes what's in that vial, the fentanyl that's in that vial, replaces it with saline or something else, and then returns that to the ADC for administration to patients. And so this is one that they specifically called out for that institution, which introduces other types of risks, such as infectious disease. Another institution that I know of had a very similar experience with their large PCA syringes, so the 25 ml syringes, that were the medication was being diverted in much the same way, that the liquid inside of the syringe was removed and replaced, in this instance with the PCA, was replaced with tap water. And the way that they were able to identify that it was a diversion case and to stop it from occurring again was through infection prevention, because many of their patients had developed sepsis and were getting septic from the bacteria that were in these PCA syringes. And once they were able to make that link and find that commonality among all those patients, that they were all on a certain type of PCA, and then they went and tested those PCAs to see if it was a preparation error by the pharmacy or something, to see how that bacteria, or if that bacteria was there, they found out that yes, the bacteria was there, and then they found out also that there was no drug there either, so it turned into a diversion case. And so all these high-risk activities that those who are diverting medications can engage in ultimately do impact the care that's being provided to our patients. So when you think of a program structure, some of the questions you may think about is, is your program adequate? Do you have the controls in place at each of those steps along the medication use process? Do you have something in each of those areas that you're using, a method that you're using to monitor? Are you auditing each of those areas, which we'll talk about in a moment? And then, is it enough? Are you doing it once a year, looking at it? Are you doing it once a quarter, once a month? There isn't an exact recipe. It does depend on your situation and your resources, but just to ask yourself that question. If you don't have a program, where do you start? I had mentioned this at a previous presentation, that it may seem overwhelming to start a program from the ground up. And anytime you have a big project like that, the old saying is, you have to eat the elephant one bite at a time. The question that I would have when someone mentions that is, that's great, I'll do that, but where do I start? Do I start at the trunk? Do I start at the legs? Do I start back at the tail? What bite do I need to take first? And the toolkit can help you with that. And are you focusing in on the right areas? each of our hospitals, we all have limited resources that we can draw from to help with our diversion program. And so focusing the resources on the highest risk areas, and then once those are covered, if you have additional bandwidth, additional resources, you can look at the other areas, but ensuring that the ones that are at highest risk are the ones that you focus on first. And so talking about eating that elephant one bite at a time, the things that I would recommend if you haven't done so already or take a look at, number one would be that staff education. I think that is very important for our staff to be aware of the risks of diversion, that it can happen in our institution, that it can happen among your peers, and that we need to be aware of it and willing to report if we have any suspicions or any concerns. Most cases of diversion that are identified are because someone reported a concern that they had, something that they saw, something that they weren't comfortable with, rather than something that a person in a position like myself found because of surveillance or monitoring. So it is very important that the education be in place. And again, like I had mentioned before, linking the diversion practices that we have to patient safety and the need to prevent diversion and how that impacts patients. The second thing that I would recommend that you do is go into the toolkit and look at the self-audit checklist. And this checklist has a list of, it's several pages long, so it's a long list of things that you should think about and consider for your organization. If you have automated dispensing cabinets, are you managing those appropriately as it pertains to controlled substances? What are you doing in your inpatient pharmacy? What are you doing in your outpatient pharmacies? What are you doing as far as administration practices for the nursing? Those are all covered in there, as well as are you meeting all the DEA regulations? One of the items that was pulled out of this diversion event that we're referencing was that they were not compliant with all the DEA regulations. They thought that they were, and so they did this, innocently, if you will. It wasn't because they didn't want to follow it. They thought they were following it, but they weren't following it as well as they needed to be. And so going through and just evaluating to ensure that you are following everything. One of the items that's on the checklist that, again, this institution failed to do is that they did have automated dispensing cabinets, and they utilized blind counts. And if the counts were off, those cabinets generated discrepancies. But the institution was unable to provide documentation to show that those discrepancies were properly identified, investigated, and resolved. So that's something to ensure you have the process in place, you have the blind counts in place, you have the discrepancies generated so that you can look into them, but are they actually being looked into? Are they actually being investigated, and are practices changing because of that? As well as ensuring that the institutions are knowledgeable about what's going on is another piece of this checklist. Is once you've done that, to inform senior leadership at your hospital of what's going on, what the practices are, where the gaps may be. As it says, one of the other areas of improvement that they had were their key personnel were not sufficiently knowledgeable around their controlled substance practices. And so you don't want to have that as you're going through. So that's a great way to help prevent that, is through that checklist and that self-audit. So here's some examples. This is definitely not an all-inclusive list, but some examples of things that you may do in your surveillance and monitoring practices to help form that structure around your controlled substance diversion prevention program. Using medication rounds, you can include controlled substance rounds in there as you're looking at tracers. You're doing these mock tracers for regulatory compliance, or you're doing medication safety rounds to ask the questions around controlled substances, looking, are they being stored properly? Are they being administered properly? Asking the questions to the nurses of how they handle it, how they're wasting, what their wasting practices are, what their return practices are, talking to the technicians, just gathering that information, because again, you may have the right policies and procedures in place, but there may be that drift that's occurred that will be discovered when you talk to those actually performing the work. Rounding on patients, asking them how their pain control's been, reviewing different transactions and reconciling those transactions. One thing that I'm not going to say one way or the other, but I do think based on what we found with the other institutions that had the visit, is at least have the discussion around urine drug screens. Should they be random or should they be for cause? And there's arguments on both sides, and like I mentioned, it's not something that we're going to say one way or the other than ensure that you've had that conversation with your employee health, with those responsible for controlled substances, with your risk management or your HR departments, to ensure that you all agree on the best way for your institution to move forward with that. And then whenever feasible, to help monitor all these transactions and to help with the monitoring using advanced analytics whenever possible. There's many different vendors that have this out there. There's ones that will come do it for you, and you can contract out to them, ones that you can purchase yourself and use them. But whenever feasible, that is something that is also very beneficial. So when you're looking at auditing, again, these are some of the areas that you should consider auditing to ensure that the policies that you have in place, the procedures that you have in place are being followed and are robust enough to limit the potential for diversion. And then the audits will help to detect any of that diversion that may be taking place. Each of these areas have different practices, so you have to think through how you can best do it without forgetting the ones there at the bottom. Those bottom three, a lot of times, are some of the higher risk areas. You think of home care and hospice and the amount of controlled substances and narcotics that are used in those areas for the comfort care, for the end-of-life care, for these patients that need that may not be able to communicate their pain levels as well, and it makes it a high-risk environment. The EMS services, long-term care, skilled nursing facilities, there's lots of diversions that occur in these areas throughout the country, and so ensuring that we are not overlooking these areas, that we have pieces in place, and what can we do to audit them, to go to each of them and say, I need to see your records, I need to see what your processes are, and talking to those individuals. So when you look in the toolkit, it outlines a lot of different ways that diversion can occur. I'd mentioned it can occur at any point in the medication use process, and the toolkit will give some examples of diversions that have occurred in each of those. And we talked a little bit about monitoring for diversion, ways that you can do that. It has some benchmarking data, so you can see how you're doing compared to other hospitals, and then that self-audit checklist. One piece I didn't get into a lot that I'll get into a little bit now is the components of a diversion program. Really what those components are is there needs to be somebody in your organization that is designated as the go-to person. It doesn't need to be someone like myself that does it as a full-time position, but at least you know who that person is if there's a diversion that occurs. In the critical access hospitals, it could be the director of pharmacy or one of the other pharmacy managers in that hospital. At some of the other community hospitals, and it again could be a pharmacy manager, it could be the director of pharmacy, it could be someone in nursing that's going to take that lead. But through the education in your program, that person needs to be identified so that when concerns arise or when a diversion occurs, those in the organization know who to turn to so that they can then lead the organization through the process of that investigation and reporting. I do also recommend that in addition to having that designated person, that there is a committee that's put together, and it's a multidisciplinary committee that can review information learned from investigations or learn from best practices from other institutions. The toolkit would be a great agenda item for a future committee meeting that you may have, so that you can review and see what needs to change in your organization. Or if there's a diversion in one unit, using that committee to discuss lessons learned from that diversion and spread that across the rest of the organization to, again, reduce the likelihood that a diversion may occur elsewhere. So having pharmacy, having nursing, having physicians, having HR, having your employee health, your education group, your infection prevention. All of those components and all those people will help make that committee, that much stronger to help you make your program stronger. And it's not a committee that has to meet every month. It can meet less often, but again, just knowing that you have a group that can meet to discuss what you need to do or how you need to make improvements is extremely valuable. So next we'll go into a little bit about reporting and what needs to be reported. As this was when I first started into this position as a pharmacist, I knew that things needed to be reported to the DEA and to the Board of Pharmacy. But I will say the work that was done in this area by our group, and Anna Stein did a lot of the work here, so I want to give her that credit. It did shed some light for me, and so hopefully it'll help each of you as well as we look at this. So with any case of diversion, or I'll take that back, the reporting to the DEA must occur with any theft or significant loss. And really the reporting needs to happen to 3 different organizations in that situation. So any theft, which diversion would fall under that, or any significant loss needs to be reported to 3 different entities. And we'll talk about those 3 first. The first one being the DEA. The requirement, and this is where I got a little confused myself when I first started, the requirement is that you notify them of a theft or significant loss within 24 hours. The first diversion case that I was involved with, I will admit that I did not get that to him within that first 24 hours because my impression was I needed to have all the information, and I wasn't done with my investigation. I didn't have all the details of what actually happened or exactly how much we were missing. And so I didn't complete that Form 106 until later, and then once completed, I sent it on to them, but it wasn't within that 24-hour requirement. And what we learned when we had the DEA come to our coalition meetings and have those discussions was that the notification can simply be an email, which the toolkit provides an email address that you can use. But it can just simply be an email saying we've had what we suspect as a diversion, theft, significant loss, whatever it may be, and we're notifying you of this, and we will follow this up with a 106 submission when all the information is available. And then once you've made that notification, you complete your investigation and you complete that 106 and turn it in. The DEA asks that if it's taking longer than 2 months, that you give them a notice, say, hey, we're still working on it, we haven't forgotten about it. This is where we are, this is what we're waiting for. So you have a lot longer period to complete that reporting once you've made that initial notification. The next question that we get a lot is, what does that mean, significant loss? We know what theft is. If somebody steals 1 tablet or 1 ml and you know that they stole it or diverted it, that has to be reported. There's no quantity that's too small or too great. All those have to be reported. But then they say a significant loss needs to be reported. And we try to get them to quantify what that really means. And although we didn't get an exact number, saying no, above 10, above 5, above 100, whatever the case may be, they were able to provide us with some guidelines that you can see here in these 6 bullets that are included in that toolkit. And so this is something that I refer to on occasion to see what we're experiencing or helping a colleague is what you're experiencing. Is that considered significant loss? So I would recommend you turning to this whenever you have that question come up in your mind. The other organization that has to be reported to is the Board of Pharmacy. And they have to be reported to within 10 days, and you have to submit that report. It's the same information that's on a 106, but it's a separate report. You can't just simply send them the 106. You do have to fill out the other separate report. And then the last one is, every year when you register with the North Carolina Drug Control Unit and you fill out the 226A form, if you've had any diversions or losses that have occurred, you do have to submit that to them annually. And you have to disclose that to them when you submit your application to get that registration renewed. And so it's important that you do that and you include that. You also include any of the 106 submissions you had in the last year, police reports, any waste destruction that you've done in the last month. That's all important to include in that submission as well. So those are the three that are required for every instance of diversion. And so ensuring that your organization, and again, that's why I think having that one designated person is important, that they can keep this straight. If you have a diversion on a nursing unit, the nurse manager may not realize that they have to report that to the Board of Pharmacy. They may report it to the Board of Nursing, but it may not go through those other reports. And that, if that's found out later, it could cause some impact into the DA registration. The DA may come and fines, and there's other things that play into that. And so that's where that designated person and the structure you have with your committee and other things comes into play with this reporting. And then depending on the licensing and the individual that you're working with, there are other reporting that needs to take place. With physicians, if action's taken on their privileges, you have to report that within 30 days. With nursing, you need to report that to the Board of Nursing. Things that they say are definitely reportable include no drug abuse, impairment on duty, drug diversion, positive drug screens. So all those that play into that. Pharmacists and pharmacy technicians. Interestingly, the Board of Pharmacy requests that they be notified. It's not written into the law that they are required to be notified, but I would highly encourage you to notify the Board of Pharmacy with anything around the pharmacists and pharmacy technicians if you have cases. They're going to be notified of the diversion anyway, but if there's something that's involving a pharmacy personnel, to ensure that that's called out so they can take the proper steps to provide help to that individual. I won't go through all these, but depending on what type of worker it is, there's different areas that you would report to. And it's the same thing with students and even law enforcement. A question is, do we have to report all these cases of diversion to law enforcement? And the answer is no, you do not. The State Bureau of Investigation does request notification. They are specially trained to assist. They can help you in your investigation, so they're there for that, but it's not required that you make that notification to them. Other requirements that aren't as common, but again, each of these can impact the patient's safety, especially that tampering. So that example I gave with that fentanyl being diverted by the nurse removing the fentanyl and replacing it with saline, that is tampering. And so that case would have also had to be reported to the FDA because of that tampering. Other errors that you can see there should be reported, especially that the injectable medications, if they're involved, there should be the report to the NCHA Division of Public Health so that they can ensure that the proper steps are in place to help limit or reduce the chance of infection. The CDC has a great resource of the numerous times throughout the country that outbreaks of hepatitis C or other bloodborne pathogens have occurred as a result of diversion cases. And it can have a detrimental impact on our patients when that happens. And so we do need to report that, but also keeping that in our mind, we're doing this so we don't have those cases occur at our institutions. One of the questions that people ask, and you can read the details here on this slide, is if you're asked for a reference for an employee that you had concern about, and then they resigned and went and got work elsewhere or applied elsewhere, and you're being called as a reference, you are able to provide them with truthful statements about why that employee left or what their job performance was like. You are covered from civil liability there, as well as you're able to share HIPAA-protected information with law enforcement and other regulatory bodies like the Board of Nursing, the medical board, when you need to make those reports. This is a summary that I would encourage. It's in the toolkit to have that designated person have this quickly available so that all the information I gave you is summarized into one table and makes it easy to identify what needs to happen. And so with that said, I do want to turn it back over to Angela that will talk a little bit more about how you can actually apply this directly to your hospitals.
Thanks, Evan. So again, I work at Pender Memorial Hospital. It's a critical access hospital in Burgaw, North Carolina. We have limited staff. I also hold a management position at New Hanover Regional Medical Center, so my time is split between the two facilities. So a lot of my day-to-day diversion prevention program is managed by my lead technician. But we do a daily review of controlled substance activities for the previous 24 hours in our facility. My lead technician looks at numerous indices or metrics over the month. She audits random days, the nursing units that have controlled substances. She reviews every OR case that we do to make sure that drug removals match administration and documentation. She also looks at is there a trend or how many full waste or missing or late wastage documentation occurs on the unit. And then I also look at things like undocumented waste. I look at discrepancies that occur in our automated dispensing system. We each look at different pieces of it and converse often about things that we found. Then monthly we take our reports and audits, and we at Pender have made the decision to hire an independent consultant group to help us with our diversion prevention. So this company receives our monthly, our previous month's activity on our reporting and auditing, and then they send us back we call a hot list of pharmacy or nursing members that may need a closer look with their activity based on the reports that we have sent from our work. I share this information with our chief nurse executive. I'm the one who does that in-depth review, and then depending on my findings, I will have a meeting with the nurse manager for that, the nurse that was involved. If it's a pharmacy person, I would then meet with my one-up to talk about what I'd found. And then twice a year, this independent consultant actually comes to our facility, and her name is Michelle, and she will look back from the last time that she visited all of our controlled substance ordering, our invoices, our filings, our entry into our automated dispensing cabinet. And Michelle is a former DEA agent, so she knows what she's looking for. She also will make visits out to the nursing units to spot check nurses and ask them, what is your procedure for? How do you do this? What do you do if this happens? She also looks and randomly pulls various patient records for the past 60 days to do chart audits. At the end of her visit, she'll give me a verbal report out, but then she'll send a final written summary to me, and I share that with the president of our hospital, again, the chief nurse executive, and with our network pharmacy director. All of this is shared among, and I give them a clean copy, and then I give them my quote-unquote annotated copy to let them know for things that involve pharmacy what I am doing to correct or to prevent from happening in the future. This would be the equivalent of, Michelle is my equivalent to someone like Evan that can help me, because I don't see a lot of diversion here. But the one time that I do, she's going to help walk me through what this is. We also have committees set up that should diversion occur, we have a committee to pull together. One of the things that I would like to do, because it doesn't happen often, is to have a dry run. Let's just say nurse X or pharmacist Y had some suspicious activity. Where do we go from here and give it a try? We have not done that yet, but that would be my place that we could improve. So overall, we just want to say, number one, we appreciate your time and the time that you've spent with us this afternoon. So it's precious. we just want you to know that the toolkit is here for you, that we want you to use the information within the toolkit to enhance what you already have, to augment, or to even just give you hints on where to start. The website is listed there. You can also just Google search North Carolina Opioid Stewardship, and it will take you to the Healthcare Association's page. Do make sure you identify who's going to be on your diversion team. That will help a lot in the chaos that may or may not occur should something happen. And make sure everybody knows what their role is and what the process is. And that's where that practice, that tabletop drill, may come in to be helpful. So that is all that we have. At this point, we would be glad to talk with you more about your experiences, if you have anything to share, or if you have questions for us.
Thank you, Evan and Angela. A few things. I know that sometimes you hear all that and you hear those stories. It can feel overwhelming. But what we want to encourage you to do is take a look through that toolkit, and then also reach out to Dean and Kim and myself to figure out what parts of that toolkit you guys as a system would like to implement. We are here to help provide some guidance and support for you all. I know that's a lot of information to process all at once, but as you think through the diversion work that's happening in your system and in your hospitals, think through, as they noted, where your gaps are and how you can ensure that not only are your patients being safe, but your workforce is thriving. And so that wellness programs upstream all the way through the reporting and monitoring keep you safe from a financial perspective, from a quality perspective, and from a perspective of good governance. So those are just a few points that I think are really vital. And so we'll open it up to questions. And if you have any, we'll leave it open for a couple minutes, and we'll raise your hand and we'll unmute the mic. Great. So we're going to continue to move along. We have a couple of updates for you. So I'm going to turn it over to Dean, who's going to talk through a few of the upcoming portions for your PSO work.
Thanks, Jay. Hi, everyone. Just a few slides here. We've been sending out a lot of information via email and the PSO newsletter, but just want to kind of highlight a few things and make sure that everyone is aware of some of the upcoming events and activities within the PSO. So first of all, you all should have seen, all those who are PSO leads and primary points of contact, the 2018 end of year report summaries that came out were sent out last week via secure email. So we do encourage you to look through those. The more data you submit, obviously the more robust those reports become, the more feedback we're able to give you on your data. But we do encourage you to share those with your senior leadership and others that are engaged in the PSO work. And then most importantly, let us know moving forward how we can enhance the value of those reports so they are more meaningful to you and your organizations. Also, we communicated in the January-February newsletter that we want to make sure that we have current contact information for all of our PSO members. So one of our goals is to make sure that we're better disseminating information, not just to the primary contacts, but others within the organization. And obviously acknowledging that sometimes there is turnover and change. We want to make sure that we have current points of contact so we can get information and also target different types of information to the appropriate people. So you go back to the newsletter we sent out and you'll see there's a PSO contact update form. Just click that link and that's your opportunity to keep us informed of updates to your contacts. And we'll also put that on the website so it's more easily accessible as well. Just again, we've been promoting this pretty heavily, but I just want to make sure everyone takes full advantage of some of the other great webinar opportunities coming up. We have a two-part series that's being led by one of our PSO partners, members here at UNC. It's a great patient safety program that they developed out of UNC with some great results. Shows how they kind of engineered their systems to improve quality and safety, not just safety outcomes, but also patient safety culture and also improve their operations. So Dr. Lucas Mazur and his team will present on their program and how they spread it throughout the health system and other organizations. And it'll also be a great opportunity to talk about, beyond these two webinars, how we may be able to share some of this learning with other PSO members. So that information was sent out in the newsletter and via email, so please register for those webinars. And then finally, this is a wonderful course that typically is held across the country, and it'll get usually close to the Raleigh-Durham area or North Carolina, but we're fortunate to be able to partner with Outcome Ingenuity to bring the Just Culture Certification Program and the Trainer Program to Cary here at NCHA. So that's coming up next month. There's still plenty of seats available, and I want you to take full advantage of this because for those who are familiar with Just Culture, it's a great way to improve your safety culture and encourage reporting and improve patient safety. Should be a cornerstone of your patient safety programs in your organizations. So the certification program is now a 2-day program instead of 3, which is great. And that Train the Trainer program really is an opportunity for managers to get trained and go back and provide that training, spread it throughout the organization. So it's a wonderful opportunity, and for PSO members, it's around a 40–50% discount off their standard rate. So please take advantage of that. And if you have any questions about that, feel free to email me. It's dhiggins, DHIGGINS @ncha.org. I can share more information. Oh, too far. All right, and that's all the updates.
Great, thank you guys. We will leave the line open for another minute or so, and if not, we will end the webinar early, and you guys can have your Friday afternoons back. Hopefully you had a wonderful Valentine's Day and have a great President's Day weekend. Thank you all. Have a great day. Evan, thank you so much for your help today. We appreciate it. I'll follow up via email if there's anything else. Thanks.
Okay, sounds good. Thank you.